Good day everyone. We are the group 3 and we will be discussing about parasite biology, pathogenesis and clinical manifestation, diagnosis, treatment, epidemiology, and prevention and control of these following parasites: coccidians, other intestinal protozoans, babesia, blood and tissue flagellates, microporidia, intestinal cestodes, and extraintestinal cestodes.
Coccidians belong to the Ipicomplexan class Conoidacida and are a subclass of microscopic, spore-forming, single-celled obligate intracellular parasites. They must survive and reproduce within an animal cell since they are obligate intracellular parasites. So the class was defined in 1988 by Levine and contains two subclasses, which are the Coicida and the Gringarins. So all of the members of this class have a complete hollow, truncated conoid. So the life cycle of Coccidia or the Coccidian life cycle takes approximately 5 to 8 days to complete. Unsporulated oocytes are shed in the feces in the litter. The following parasites are under the Coccidian parasites, and they are Exospora bili, Cryptosporidum hominis, Cyclospora cayetanensis, Toxoplasma gondii, and Sarcocystis hominis. So, Isospora bili. The parasite biology of Isospora bili are huge, and they are 25 to 30 meters, and they are ellipsoidal in shape, so they are immature and contain only one sporoblast when expelled. So after excretion, the oocytes matures, though the single-cell sporoblast divides into two sporoblasts, which grows cyst walls and becomes sporocysts, so each containing four sporozotes. So Isospora bili is a protozoan parasite in the phylum Apicomplexa. So this group of parasites are referred to as Coccidia. So this organism can be acquired by the ingestion of sporulated oocytes found in contaminated food or water. So the life cycle of Isospora bili are large and have a typical ellipsoidal shape. So when excreted, they are immature and contain one sporoblast. The oocytes matures after excretion, which develop cyst walls, becoming sporocysts, and which eventually contain four sporozoites each. Pathogenesis and clinical manifestation. Symptoms of I. villi infection include diarrhea, steatorrhea, headaches, fevers, malaise, abdominal discomfort, vomiting, dehydration, and weight loss are all symptoms of a villi infection. The presence of blood in the feces is unusual. Parasites can be found in feces or biopsies for months or years, indicating that the condition is persistent. Recurrences are extremely common. In immune-competent patients, Isospora bili can produce a serious and sometimes fatal infection. In individuals with AIDS or other immune-impaired hosts, or infection is frequently severe, resulting in watery, secretory diarrhea that can lead to dehydration and hospitalization. So, I. villi can cause marked bilious atrophy and cyst hyperplasia in the small intestine. Diagnosis: the presence of oocytes in feces or, in rare cases, bile samples is used to diagnose Isospora bili. When handling fresh feces samples, general precautions should be observed. So universal precautions should be followed when handling fresh stool samples. Oocytes can be observed in wet preparations, iodine-stained preparations, or acid-fast-stained smears of concentrated stool specimens. Treatment: the drug of choice for Isospora infection is trimethoprim sulfamethoxazole or TMP-SMX, so also known as Bactrim, Cetra, and Contrim. TMP 160 mg with SMX 800 mg. Orally twice a day for 7 to 10 days is the normal treatment regimen for adults. Epidemiology. Isosporabilla infections are found all over the world, although they are more prevalent in tropical and subtropical areas, such as Haiti, Mexico, Brazil, El Salvador, tropical Africa, the Middle East, and Southeast Asia. So prevention. Avoiding food or drink that has been contaminated with stool could help you avoid getting sick. Hand washing and personal hygiene procedures should be followed as always. So the rationale of hand washing is to remove microorganisms from the hands, preventing the potential transfer. It is known that organisms survive and multiply on human hands, creating the opportunity to infect others or the host. So after using the restroom, changing diapers, and handling food, wash your hands with soap and water in order to avoid infection and also teach children the necessity of washing their hands.
Cryptosporidium hominis. Parasite biology. So most Cryptosporidium are 3 to 6 micrometer in size, although some reports have described larger cells. So oocytes from the organisms are extremely robust, prevalent, and source of water supplies and capable of surviving in the environment. Cryptosporidium is the leading cause of diarrheal disease and child mortality globally. It is also a member of phylum Complexa, single-celled parasites that include the causative agents of malaria and toxoplasmosis. Cryptosporidium infection is restricted to host epithelial cells within this parasite is confirmed to apical brush border. Pathogenesis and the clinical manifestation. So cryptosporidia are obligate intracellular coccidin protozoa that replicate in small bowel epithelial cells of vertebrate hosts. So the pathogenic mechanism by which cryptosporidium causes diarrhea, malabsorption, and wasting are poorly understood. Whatever these mechanisms may be, the initial host parasite interactions of attachment and invasion are critically primary events in pathogenesis. Two types of oxides that are produced. So there is thick-walled oxides, which are commonly excreted from the host, thin-walled oxides, which are primarily involved in ortho-infection. So when the infected oxides are ingested by humans or another vertebrate host, the cycle begins again. So the oxides are resistant to harsh conditions, including chlorine levels, usually used in public water treatment systems and swimming pools. So the parasite Cryptosporidium causes cryptosporidiosis. The parasite enters your body and infects your stool after passing through your digestive tract. Anything contaminated with infected excrement can spread the infection to others. Diagnosis. So stool samples are examined to determine the presence of cryptosporidiosis. So the stool specimens are often analyzed microscopically using various methods. Example are the acid-fast staining and the direct fluorescent antibody. So the treatment supported measures oral infrared parenteral rehydration and hyperalimentation may be needed for immunocompromised patients with severe disease. So, for severe or persistent infections, oral nitazoxanide is used. The recommended dose is given for 3 days. So, in the age of 1 to 3, 100 milligrams 2 times a day. In the age of 4 to 11 years old, 200 milligrams 2 times a day. In the age of 12 years old and above, 500 milligrams 2 times a day. Epidemiology. So, Cryptosporidium species infect a wide range of animals. So, they're also responsible for most human cases of cryptosporidiosis. Ingesting even a relatively small number of oocytes can result in disease. Infections result from the following: ingestion of fecally contaminated food or water, direct person-to-person contact, zoonotic spread, and the disease occur worldwide. So, Peridosis is responsible for 0.6 to 7.3 of diarrheal illness in developed countries and even higher percentage in areas with poor sanitation. So these are the life cycle of the Cryptosporidium. So it started from the thick-walled oxides, which is that exist in the host and digestive tract. Then the contamination of water and the food oxides, and it can be found in recreational water such as swimming pools or public pools, or even in drinking water. So the thick walled oxides ingested by host, then it will be in the infective stage. Prevention and control. So wash your hands, practice safer sex, avoid touching farm animals, avoid touching the stools of the pets, avoid swallowing water when swimming in the ocean, lakes, rivers, or pools, drink safe water, and also practice extra caution when traveling. So good day, I'm gonna talk about the Cyclospora cayetanensis. So here in the picture, it shows the C. cayetanensis parasite. So it is round, measured about 8 to 10 micrometer, and it has no internal structures visible, and it may have wrinkled appearance. So first, I'm gonna talk about the parasite biology. So, Cyclospora cayetanensis is a coccidian protozoan. So, it appears that all the human cases are caused by this species, and no animal reservoirs for C. cayetanensis have been identified. So, the outbreaks are associated with contaminated water and imported products from developing nations. So, the distribution of this parasite is worldwide. So its related oocytes are ingested by humans, causing infection. So Zika yatenensis infection causes broad range of clinical manifestations and high relapse rate. So this picture is shows the life cycle of C. cayetanensis. So once in the gastrointestinal tract, parasites are released from the oocytes and infect the epithelial cells of the small intestines, as you can see here in the picture. So within epithelial cells, parasites undergo asexual and sexual reproduction to form new oocytes. So when passed in stool, here in the excretion of unsporulated oocytes are still not infectious. So it takes 10 to 12 days for the oocytes to mature, and here in unsporulated oocytes, they already sporulate in the environment, so prior to becoming infectious. So here it already contaminates the vegetables, fruits, and water production. And also, the sporulated oocytes are ingested through contaminated water or food taken by a human, and then the cycle continues. So the transmission of the cayetanensis is by fecal oral route, and the outbreaks have also been linked to the contaminated water and produced products like the vegetables and water. So next is the pathogenesis and clinical manifestations. So the clinical manifestations of C. cayetanensis range from asymptomatic infection to severe watery diarrhea. So asymptomatic infections more common in parasite endemic settings, and children and elderly individuals tend to present with more severe symptoms. When watery diarrhea occurs, it lasts about 1 to 3 weeks, so typically accompanied by nausea, vomiting, fatigue, fever, and abdominal pain. So, in patients with AIDS, so symptoms can last up to 12 weeks. Recurrence of symptoms can occur in up to 40% of patients after treatment. So, biliary disease is possible in both immunocompetent and immunocompromised hosts infected with C. cayetanensis. So, next is the diagnosis. So, microscopic detection of the oocytes, the wet mounts, and the special staining in concentrated stool specimens is a gold standard for diagnosis. So both wet mounts and special stains, the modified acid fast stain and modified triachrome stain, can be used to visualize the oocytes. So next is the treatment. So the untreated infection can last up to 10 to 12 weeks. And the treatment of choice is the trimethoprim and sulfamethoxazole. So with AIDS patients, higher doses may be required with a long-term maintenance therapy. So the epidemiology naman is the Cyclospora caetanensis is a oxygen protozoan parasite that is found all over the world, and it is the only Cyclospora species that can infect the humans. And outbreaks are most commonly recorded in tropical and subtropical locations, but several have recently occurred in United States and Canada. So the outbreaks are industrialized nations have been associated with produce import from developing countries. So next is the prevention and control. So based on current research, the best strategy to avoid cyclosporiasis is to avoid eating or drinking anything that has been contaminated with feces. So the travelers to cyclosporiasis endemic areas should be aware that chemical disinfections or sanitations of the water or food is unlikely to destroy the cyclosporia. So there is no cyclosporiasis vaccination available yet. So we just have to be careful about what we eat and drink in a strange or in a foreign country. So better to bring our own food or own bottled water or buy our own bottled of water to avoid infected by the Cyclospora cayetanensis. Toxoplasma gondii, parasite biology. So the most common mammal that it considered as a host were cats, and also it infects birds. So this may transfer to humans when infected meat is consumed. Then it will stay at the intestine of humans and cause various diseases. Then the life cycle. Oocysts become infected from environment, and oocyst transforms into tachyzoids shortly after being ingested. Pathogenesis and clinical manifestation. So when you are infected of Toxoplasma gondii, you may suffer from congenital retinal and brain infections, and you may lose your vision, as well as causes mental impairment such as encephalitis. And very worse to those patients that have less immune system. Then the diagnosis. So the condition is evaluated by serology and examination of tissues. Treatment includes pyrethroid and sulfadiazine and also folinic acid. Epidemiology. So no specific country because it is prevalent all throughout the world. And you may acquire this parasite through ingestion of undercooked meat and food contaminated with cat feces. Prevention and control. So these could be avoided by cooking meat thoroughly and of course maintain a hygienic environment.
Sarcocystis hominis. Biology. Sarcocystis hominis is acquired by ingestion of uncooked beef containing S. hominis sarcosis. The simplest form of Sarcocystis is zoid, a banana-shaped cell with a pointed end that allows it to infiltrate host cells. So, Sarcosis hominis life cycle. Both related oocysts containing two sporocysts and individual sporocysts can be passed in stool. The number one, sporocysts contain four sporozoids and a refractory residual body. Sporocysts ingested by the intermediate host, such as cattle for S. hominis and pigs for S. hominis, rupture releasing sporozoids. Sporozoid blood vessels and undergoes schizogony, resulting in first generation schizons. Merozoites derived from the first generation invade small capillaries and blood vessels, becoming second generation schizons. The second generation merozoites invade muscle cells and develop into sarcosis containing bradyzoids, which are the infected stage for the dependent host. The number two, humans become infected when they eat undercooked meat containing their sarcosis. Bradyzoids are released from the ruptured cyst in the small intestine. Number three, invade the lamina propria of the intestinal epithelium. 4. They differentiate into macro and microgametocytes, fusion of male and female gametes. 5. It results in formation of oocysts. Then, oocysts sporulate in the intestinal epithelium and are shed from the host in feces. Finally, due to the fragile nature of the oocyst wall, individual sporocysts may also be detected in feces. Sarcocysts that can be seen with the naked eye are known as macrocysts. Microcysts are only visible with a microscope. So this is the life cycle of Sarcocystis hominis. Pathogenesis and clinical manifestation. Signs and symptoms of human sarcocystosis include gastroenteritis with diarrhea, eosinophilic enteritis, myalgia, weakness and a slight rise in creatine kinase in reported instances. Fever and more severe symptoms were seen in immunocompromised patients. Sarcocystic infection can cause abortion in pregnant animals, especially in cows. In most cases, severe infections end in paralysis or even death. Diagnosis. In fecal specimens, identifying sporosis might be problematic. The sporosis in the definitive host can be discovered using the fecal flotation method. The schizons are discovered in the intermediate host, skeletal muscle, and brain tissue using microscopy. Microcysts in damaged tissue of some animals can be seen through histological examination. Serologic tests like the indirect fluorescent antibody or IFA test and the enzyme-linked immunosorbent assay or ELISA have been shown to be successful. Complement fixation and dermal sensitivity tests are also viable options. The polymerase chain reaction or PCR test for antibodies in spinal fluid is ineffective. Treatment. In the case of sarcocystic infection, there is no known effective treatment. Individuals appear to be unharmed by eating partially cooked meat. When cysts deteriorate, lesions are infrequently seen. Epidemiology. Only a few cases of human sarc- Epidemiology. Only a few cases of human sarcocystosis have been reported in Southeast Asia. Cattle, horses, dogs, cats, rabbits, mice, and chickens are among the species that can be infected with sarcocystitis. Some dog species in North America have a common parasite illness. The mode of transfer from one animal to another is unknown. Sporocysts can keep their infectivity for months in water at 4 to 10 degrees Celsius. In hot, dry environments, sporocysts are unable to survive for long. Macrocysts extracted from sheep were shown to live for 13 days at 10 degrees Celsius and 20 days at 4 degrees Celsius in an experiment. However, freezing meat has not been proved to stop the spread of sarcocystitis. Other investigations have indicated that to kill sheep macrocysts, they must be heated for 20 minutes at 60 degrees Celsius. Prevention. There are currently no known treatments for this condition. So, however, it is not recommended that raw animal carcasses be offered to other animals. Food animals that are extensively afflicted, even if they are not toxic to people, should be declared unfit for human consumption. So these are the references.
Blastocystis suminis. Parasite biology. Blastocystis is a genetically diversified unicellular parasitic parasite with a known pathogenic potential that colonizes the intestine of people, non-human animals. The organism has been characterized as the straminophile based on molecular evidence. Straminophiles include organisms such as diatoms, chrysophytes, water moles, slime nets. Pathogenesis and clinical manifestation. The most common symptoms was abdominal pain, which about 96.9%, and diarrhea and distension were reported in 50% and 32.6% of cases respectively. When B is present, it is common to detect signs in the intestine when other agents are eliminated. Hominis in this protozoan may be considered an intestinal pathogen. Diagnosis. Hominis is usually diagnosed by examining feces stained with iodine or trichrome under a microscope. Because fecal detritus could be confused for the organism, the moist preparation. A permanent stain smear is desirable. Treatment. Treatment includes antibiotics such as metronidazole or what we call flagyl and tendazole are used to treat infections or tendamax. Also, sulfamethoxazole and trimethoprim are examples of combination medicines, Bactrim, Septra, and others. Also, anti-protozoal drugs like paromomycin and nitazoxanide or Alinia. Epidemiology. It is the most common parasite detected in human stool samples, with a prevalence of 60 to 50% in underdeveloped nations compared to developed countries, for about of 10% or less. Prevention and control. The best way to avoid cystis infection is to keep your hands clean. We need to wash fruits and vegetables before eating them. Cooking surfaces should be kept clean, and we need to wash our hands often.
Genta mueva fragilis. It is important cause it travelers diarrhea, chronic diarrhea, fatigue, and in children fails to thrive. Infection with D. fragilis, called giantamoebiasis, is associated variously with symptoms of abdominal pain, diarrhea, weight loss, nausea, fatigue, and fever. Life cycle of Giantamoeba fragilis has not yet been illustrated. As assumptions have been made on the basis of clinical observation of the biology and related species. Trapezoids are found in the lumen of the large intestines where they multiply via binary fusions and are shed in the stool. Parasite biology. A species of single-celled exudates found in the gastrointestinal tract of some humans, pigs, and gorillas. It causes gastrointestinal upset in some people, but not in the others. The fragilis is one of the smaller parasites that are able to live in the human intestine. Gentamoebiasis fragilis cells are able to survive and move in fresh feces, but are sensitive to aerobic environments. They dissociate when in contact or placed in saline, tap water, or distilled water. Gentamoeba fragilis is not an amoeba, but an intestinal flagellate, most closely related to trichomoniads. In human stool specimens, D. fragilis is almost always found solely as a trapezoid. However, the rare presence of putative cysts and pre-cyst form in clinical specimens has been reported. Their transmission's potential is being investigated. Pathogenesis and clinical manifestation. Since D. fragilis is known to frequently co-infect with E. vermicularis, this leads to assumption that vermicularis is a possible vector and mode of transmission. When inside host, the parasite infect the mucosal crypts of the large intestines. They primarily affect the cecum and proximal colon. From there, the trapezoids are in the lumen of the colon and are excreted as waste. D. fragilis is not considered to be invasive nor cause cell or tissue damage. The Entamoeba fragilis is a type of trichomonad, the flagellated organisms, but D. fragilis lack flagella having secondarily lost them over a voluntarily time. Thus, it is an amoeba of flagellate ancestry. Diagnosis: patients are required to provide fresh stool samples that have been preserved from parasite examination. Patient can also be tested for E. vermicularis since the two parasites are known to coincide. The multiple sample are required because of parasite detection being difficult. Therefore, a sample might be obtained each day to help increase the sensitivity. Treatment: the age and clinical status of the patient will determine the treatment given. If the patient is a child, a temporary treatment will be offered to test if symptoms can be alleviated. If the child is asymptomatic, then treatment is not necessary. Epidemiology: Gentamueba fragilis has an estimated prevalence throughout the United States. D. fragilis is more prevalent in well-developed countries as opposed to disadvantaged and resource-poor nations. The parasite is also endemic in crowded communities, population with unsatisfactory sanitation conditions and individuals who travel to underprivileged countries. Gentamueva fragilis and an estimated prevalence throughout the United States. Unlike majority of parasitic infection, D. fragilis is more prevalent in well-developed countries. Recently, D. fragilis was considered to be more prevalent than Giardia, thus leading to better diagnosis. Globally, the prevalence of D. fragilis ranged from 0.3% to 90% occurring in multiple countries, including many urbanized cities such as Los Angeles, California, and Sydney, Australia. Prevention and control: wash your hands with soap and warm water after using the toilet, after changing diaper, and before preparing or eating food, and teach children the importance of washing hands to prevent infection. Exclude people with diarrhea from childcare, preschool, and work until there has been no diarrhea for at least 24 hours. Infant, children, and adults with diarrhea should not swim until there has been no diarrhea for 24 hours.
P. falciparum. Parasite biology. Malaria is one of the deadliest infectious diseases that affects humans. It is clinically and economically troublesome since it is widespread in underprivileged countries and regions, severely impeding socio-economic progress. Malaria's pathogenic agents are unicellular protozoan parasites of the genus Plasmodium. The parasite biology. Plasmodium falciparum is a human unicellular parasite and the most deadly Plasmodium species that causes malaria. The parasite is spread by the bite of a female Anopheles mosquito and produces falciparum malaria, the most serious form of the disease. Pathogenesis and clinical manifestation. Human P. falciparum infection is caused by a complex interplay of parasite-induced RBC changes and microcirculatory abnormalities, which are accompanied by local and systemic immunological responses, resulting in different clinical manifestation of varying severity. RBC infected with early parasite stages called rings have mild changes in adhesion and or deformability properties and can circulate, whereas late parasite stages known as trophozoites and schizoids mature forms have substantial changes in adhesion or deformability that favor their sequestration in small vessels, preventing their circulation in the peripheral blood. So this is an illustration about the life cycle of the said parasite. So female mosquitoes like Anopheles suck human blood. So they take blood meals for egg production. Interestingly, these blood meals are the link between the human and the mosquito host in the parasite life cycle. Basically, the natural history of malaria involves cyclical infection of humans and female Anopheles mosquitoes. And when we say cyclical, it means it happens again and again. So first, humans get infected with malaria when a Plasmodium parasite infected mosquito bites them. The parasite is then released into their bloodstreams. Furthermore, they grow and multiply first in the liver cells and then in the red cells of the blood, due to which the infected cells burst open. Hence, parasites growing inside the red blood cells release daughter parasites that continue the cycle by invading other red cells. So then, in the blood stage, parasites are responsible for causing the symptoms of malaria in humans. However, when these forms of parasites are ingested during blood feeding by a female Anopheles, they begin a cycle of growth and multiplication in the mosquito, following which a form of the parasite called a sporozoite migrates to the mosquito's salivary glands. Now, when the Anopheles mosquito sucks the blood from another human, anticoagulant saliva is injected together with the sporozoites. What happens here is that when they bite their victim, a protein in their saliva acts as an anticoagulant, which keeps their victim's blood flowing while they feed, which then migrate to the liver, ultimately beginning a new cycle. The parasite's multiplication in the mosquito is known as the sporogonic cycle. Also, the malaria's parasite life cycle involves two hosts. During a blood meal, a malaria-infected female Anopheles mosquito injects sporozoites into the human host, following which sporozoites infect liver cells and mature into schizoids to release merozoites. Inoculation of sporozoites into a new human host continues the malaria life cycle. Diagnosis. Microscopy of stained thin and thick blood smears is used to make parasitological diagnosis. If microscopy is not available, a rapid diagnostic test for parasite antigens can be conducted. So here are the treatments. We have the artemether-lumefantrine, which is the recommended option if available. We also have the Otovac 1 Progbanil, which are fixed dose combination therapies that can be administered for young patients weighing less than 5 kilograms. The quinine sulfate in combination with doxycycline, tetracycline, or clindamycin is another treatment option. Quinine sulfate plus either doxycycline or tetracycline is often recommended over quinine sulfate plus clindamycin. So here is the epidemiology. Plasmodium falciparum malaria is the most prevalent cause of severe and life-threatening malaria. This parasite is found in many African countries south of the Sahara Desert. People who had a high level of exposure to the parasites, bites of P. falciparum affected are most likely to be infected. As you can see here, the areas that are shaded with a brown color illustrates the region that are most affected, while the ones that are yellow are the regions that has the least cases. Prevention and control. There is currently no approved malaria vaccine because Plasmodium falciparum is a genetically complicated parasite with extremely variable antigenic surface proteins. Malaria prevention and control have three principal components, such as 1. Reduced interaction between the vector and the human host. Number 2. Illness prevention by prophylactic use of antimalarial medications. And 3. Proper treatment of malaria episodes to reduce the likelihood of transmission.
PVvax or malaria. The parasite biology is Plasmodium vivax is a genus of blood parasites or Plasmodium vivax infects a variety of vertebrate species and has roughly 156 identified species. So P. falciparum, P. vivax, and P. ovale and P. malariae are regarded real human parasites since they use humans almost entirely as a natural intermediate host. So, the second most prevalent cause of malaria worldwide and the leading cause of malaria outside of Africa. So, they form hypnozoites a small stage that nestles or snuggle inside an individual liver cell. Pathogenesis and clinical manifestation. Initial nonspecific symptoms of the disease include fever with chills, headache, muscular discomfort, nausea, vomiting, appetite loss, and arthralgia in the uncomplicated variety. So after the infection, blood stage phase had lasted 48 hours. So the increased deformability of the infected red blood cells in an apparent paucity of parasite sequestration. So an attack usually starts with shivering and chills, followed by a high fever, then followed by a sweating and a return to normal temperature. So the signs and symptoms totally begin within a few weeks after being bitten by an infected mosquito. So to add on, the life cycle of PVVAX and PO-Valley is digenetic. So in example, it involves two hosts, the man and mosquito. Female Anopheles or female mosquito is the primary host or definite host. The sexual cycle is completed in it, so it involves two phases, gametogony and sprogony. A human is a secondary or intermediate host. The asexual phase of the life cycle is completed in man by schizogony or this parasite undergoes multiple rounds of nuclear division without cytoplasmic division followed by a budding or segmentation to form progeny. So next is the diagnosis. So microscopy analysis of a Giemsia stained blood smear or use of an immunochromatographic cassette containing monoclonal antibodies to a PVVAX antigen are required for reliable identification of PVVAX malaria in an acutely unwell patient seeking routine care. So it may also be difficult and the control and elimination of the present special challenges. Treatment. Currently, PVVAX is treated with chloroquine or artemisinin combination therapy or ACT for the blood stage infection. Besides, chloroquine is used to prevent and treat malaria. It is also used to treat liver infection caused by protozoa or extraintestinal amoebiasis. So the US Food and Drug Administration or the FDA has approved that tafenoquine or quintafel for the radical cure of Plasmodium vivax malaria. Chloroquine may also be used to treat coronavirus in certain hospitalized patients. Epidemiology. Plasmodium vivax is the most common type of human malaria, affecting 2.5 billion people worldwide. Malaria occurs primarily in tropical and some subtropical regions of Africa, Central and South America, Asia, and Oceania. So there is tremendous geographic variation in intensity of transmission and risk of infection. Prevention and control. Vivax can often be prevented by the use of anti-malarial drugs and use of protection measures against mosquito bites. Insect repellent and insecticide-treated bed netting reduce malaria infections by 80%. So the picture here represents the life-saving barrier in preventing PVVAX.
So good day, I am Jana Corinvi. I'm gonna talk about the Plasmodium malariae. So here in the picture is a picture of P. malariae. So first I'm gonna talk about this parasite biology. So malaria is an infectious disease caused by a parasite that's transmitted by the bite of female Anopheles mosquitoes, and the illness results in recurrent attacks of chills and fever. So it can be deadly. So human malaria can be caused by four species of the genus, the P. falciparum, P. vivax, P. ovale, and P. malariae. And among all these genuses, P. falciparum is the most deadly. So malaria has been virtually eradicated in countries with temperate climates, but it's prevalent in tropical and subtropical countries. So if you're traveling to malaria endemic places, take precautions before, during, and after your trip. So is the picture of a vector, Anopheles mosquito, pumping blood which transmits the malaria. So here is the picture of malaria transmission cycle. So the transmitter vector of the Plasmodium parasite to humans is a female Anopheles mosquito. So when this mosquito bites a person, the first infected person it is infected with malaria. So it ingests a form of the parasite called the gametocytes, and the plasmodium completes part of its life cycle inside the mosquito, eventually making its way to the mosquito's salivary glands. And then when the mosquito bites you, the first infected person, it injects the parasite into your liver cells, and it develops for a week or so. So the liver then cells eventually burst, releasing a multiplied form of infection. The liver cells eventually burst, releasing a multiplied form of the infection into your bloodstream. And then once in your red blood cells, the parasite reproduce further, and some develop into the form that's available to be ingested by a mosquito or the gametocytes. And then bites a person, the second infected person, and thus renewing the cycle of the transmission of malaria. So next is the pathogenesis and clinical manifestations. So severe malaria is predominantly caused by Plasmodium falciparum because of its ability to induce infected red blood cells or the RBC cytoadherence to the vascular endothelium and consequent end organ dysfunction. So here in the picture, it shows the red blood cells, infected red blood cells. So fever, at first the fever may be continual or erratic. So the classical tertian or quartan fever only appears after some days, and it is accompanied by rigorous and drenching sweats. So the physical examination under the creatinensis is tachycardia, fever, anemia, hepatomegaly, and splenomegaly. So in pre-falciparum infected, it has the symptoms like anemia, diarrhea, jaundice, acute kidney injury, acute coma respiratory distress, disseminated intravascular coagulation or the DIC, and breathlessness. So the diagnosis. So it is originated or living in an endemic area. Fever or history of high fever, manifestations of affected renal, fluid and electrolyte disturbances, and glomerulonephritis. Malaria parasites, findings in blood culture, and other that causes eliminated. So after noting the symptoms and travel history, the doctor will likely obtain a sample smear of the patient's blood for observation under a microscope. So the two blood samples taken at 6 and 12-hour intervals can usually form the presence of the malaria parasites and its type. So the other differential diagnoses include the dengue fever, influenza, leptospirosis, meningitis, typhoid fever, and pneumonia. So in treatment, several medications for malaria, and these are the chloroquine, quinine sulfate, hydroxychloroquine, combination of sulfadoxine and pyrimethamine, nefloquine, combination of atovaquone and preconil, and deoxycycline. So in artemisinin-derived medication, so another class of antimalarial drugs often prescribed in Asia and now in other parts of the world. So it is derived from the artemisinin, a sweet wormwood extract. Next is the halofantrine. So if you've been taking mefloquine for prevention of malaria, or if you have heart problems, don't take halofantrine because it can be dangerous and possibly fatal to your health. So next is the primaquine. So this drug may be given um, to fight and so next is the primaquine. So this drug may be given to fight the dormant liver, form the parasite, and prevent relapses. So don't take primaquine until you've passed a screening test for G6PD deficiency. So next is the epidemiology. So according to World Health Organization report, malaria prevalence in the world ranges between 300 to 50 million per year, and the mortality rate of 1.5 to 2.7 million per year, and amount of 90% in Africa, and mostly affecting the children below 5 years old. So males and females are affected equally. So however, malaria may be devastating during the pregnancy to the mother and the fetus. So P. falciparum is the primary species responsible for increased morbidity and mortality rate in pregnancy. So young children aged from 6 months to 3 years old who lived in endemic areas are at increased risk for death due to malaria. For travelers without immunity are at increased mortality risk regardless of age. So next is the prevention and control. So there is no effective vaccine against malaria. So in countries where the disease is endemic, prevention involves keeping mosquitoes away from humans, and this includes the use of insecticide-treated mosquito netting and spraying indoor walls with insecticide. You have also to remove the stagnant water around the house so mosquitoes cannot breed and use the insect repellent. So these are our references. And then we'll be discussing about babesia, blood and tissue, Trypanosoma cruzi, Trypanosoma brucei, Trypanosoma brucei, Leishmanias, L. tropica, and L. brasiliensis. Babesia, parasite biology. So this parasite was contained by ticks or garrapata. Then it is transferred into mammalian hosts. More move by bending and gliding. They multiply by binary fission in the blood cells. Pathogenesis and clinical manifestation. So for an instance, the tick is going into your skin and it will transfer into parasite through its saliva. Symptoms of infection include chills, headaches, general tiredness, discomfort, and malaise. Can also cause anemia, jaundice, shortness of breath, and hemoglobinuria in severe cases. And the diagnosis. Babesia infection is identified through blood clotting. Treatment includes oral athuvapun in combination with oral azithromycin and blood exchange transfusion on severe cases. Epidemiology, more prevalent at northeastern United States, also at European regions. Babesiosis, very similar to malaria, that's why sometimes it was misdiagnosed. So, the prevalence of babesiosis in malaria endemic area is unknown. Prevention and control. So to avoid tick-infested regions, if found tick on skin, remove it immediately and apply common bug repellent that works against.
Blood and tissue flagellates, also known as hemiflagellates. First, the Trypanosoma cruzi. Parasite biology. Shortly after hindi nyo kita yun. Diyan. Blood and tissue flagellates, also known as hemoflagellates, that live in blood and tissues of the host. So first, Trypanosoma cruzi. Trypanosoma cruzi's life cycle. So the T. cruzi or the T. cruzi life cycle consists of three main developmental forms. Epimastigotes are an extracellular and non-effective form of the parasite found in the midgut of insect vectors, where they multiply by binary fission. As epimastigotes move to the hindgut, they differentiate into metacyclic trypomastigotes, which are non-dividing forms resistant to mammalian resist complement that have the capacity to infect mammalian cells. They enter local cells through breaks in the skin, mucous membranes, or the conjunctivas and transform into the third morphologic form, amastigotes. Amastigotes multiply intercellularly until the host cell is overwhelmed, at which point they transform into the bloodstream trypomastigotes. Pathogenesis and clinical manifestation. So acute illness is characterized by fever and widespread lymphadenopathy, cardiomyopathy associated with congestive heart failure, cardiospasm, megaesophagus, and megacolon are examples of advanced diseases that can be deadly and lead to death. Diagnosis. In sentinel diagnosis, laboratory-reared triatomine bugs are allowed to feed on patients who are suspected of being infected, and the bugs are then tested for T. cruzi. Treatment. There is no medicine that is completely effective in the treatment of Chagas disease. In acute illness, nifortimox and benzazole are only partially effective. Both medication must be used for several months and are known to cause serious side effects. Epidemiology. Approximately 200,000 instances every year. Acute illness is more common in youngsters, yet it is often undiagnosed. Lastly, prevention and control. Chagas disease prevention is based on vector control, transfusion blood, screening and sterilization, and health education, insecticide spraying, and home improvements to eliminate triatomine bug breeding grounds have been the mainstays of disease vector control.
Trypanosoma brucei. Parasite biology. Trypanosoma brucei are protozoan parasite that cause African sleeping sickness in humans in Nagana, and a cow illness that is economically devastating. Pathogenesis and clinical manifestation. Symptoms of sleeping sickness include fever, severe headaches, irritability, intense weariness, swallowing lymph nodes, and aching of muscle and joints. Diagnosis. Detecting in trypanosomes in chance fluid, lymph nodes aspirate, blood bone marrow aspirate, or cerebrospinal fluid during the rate of stages of illness. Treatment. The acute phase of trypanosmiasis. Eh, Treatment. The acute phase of trypanosomiasis or Chagas disease is treated with nifortimox or benzimidazole. Prevention and control. There is no vaccine or medication available for the prevention of African trypanosomiasis. Fly contact is minimized through preventive measure. Epidemiology. Despite the fact that sleeping sickness epidemics were once a major public health concern, the disease is now under control, with less than 600 cases of Eastern African trypanosomiasis reported to the World Health Organization in 2020. More than 50% of these were reported to Democratic Republic of Congo.
Trypanosoma brucei. This parasite is the cause of vector-borne diseases of vertebrate animals, including humans. Carried by species is Stiti, fly in sub-Saharan Africa. In humans, TBC causes African trypanosomiasis or sleeping sickness. In animals, it causes animals trypanosomiasis, also called nagana, in cattle and horses. Transmissions occurs by biting during the insect blood meal. The parasite undergo complex morphological changes as they move between insect and mammals over the course of their life cycle. Parasite biology. The ancestor of modern trypanosomes absorbed a green alga around 1 billion years ago and co-opted some of its genetic materials. This has resulted in modern trypanosomes such as TBC containing essential genes for the breakdown of sugars that are most closely related to plants. This difference may be used as the target of therapies. The relationship between the species has not been worked out to date. Pathogenesis and clinical manifestation. Two subspecies of the parasite Trypanosoma brucei, T. b. gumbians and T. b. rhodesians, causes disease in humans with clinical features of the infection dependent on the subspecies involved. Differentiation between bloodstream and Chichi midgut procyclic forms during the life cycle of the African trypanosomes is an attractive model for the analysis stage-related events. Diagnosis. The classic approach of diagnosing TB gummies infect is by light microscopic detection of the parasite in a lymph node aspirate, usually from a posterior cervical node. Early diagnosis is difficult because signs and symptoms in the first stage are nonspecific, and because diagnosis measures are insensitive. Diagnosis requires confirming the presence of the parasite in any body fluid. Treatment. Pentaminide, the recommended drug for the first stage TB gummies infection, is available in the United States. The other drugs used to treat African trypanosomiasis are not commercially available in the United States but can obtain from CDC. Anyone diagnosed with African trypanosomiasis should be treated with specific drug and treatment course depending on type and infection and disease stage. Epidemiology. TB rhodesians is found in focal areas of eastern and southeastern Africa. In 2020, fewer than 100 cases of East African trypanosomiasis were reported to WHO. Prevention and control. Wear long-sleeve t-shirts and pants of medium weight. Inspect vehicle before entering. You avoid bushes. Use insect repellent because there is no vaccine or drug against African trypanosomiasis.
Leishmaniasis tropica. Parasite biology. Leishmania tropica is a very diverse species complex with strains that may be identified ecologically, biochemically, and serologically. Zoonotic Leishmania tropica is a parasite that lives in dogs and rodents and is linked to rural disease. Anthropogenic Leishmania tropica is a human parasite that lives in urban environments. Pathogenesis and clinical manifestation. Mucosal leishmaniasis and leishmaniasis recidivans are oligoparasitic diseases with a strong cellular immune response at one end of the spectrum. Localized cutaneous leishmaniasis, the most prevalent clinical manifestation, is located in the middle of the spectrum. The life cycle of the Leishmania species. Sandflies inject infective promastigotes into a susceptible mammal during feeding. Promastigotes are phagocytosed by resident phagocytes, transform into tissue-stage amastigotes, and multiply within these cells through simple division. The parasite continues to infect phagocytic cells either at the site of cutaneous infection or in secondary lymph node organs with eventual parasitemia. Sandflies become infected through feeding on a host either with an active skin lesion in cutaneous or parasitemia in visceral. Parasites convert to promastigotes within the sandfly midgut. Promastigotes migrate from the midgut and transform into highly infectious metacyclic promastigotes. Next is diagnosis. Leishmaniasis is diagnosed by finding Leishmania parasites or through DNA in tissue specimens such as skin lesions for cutaneous leishmaniasis or bone marrow for visceral leishmaniasis, using light microscopy, molecular methods, and specialized culture techniques. And here is the treatment. Pentavalent antimonials were and continue to be the first-line medications for leishmaniasis in many endemic tropical countries due primarily to production of generic drugs. Multifacin, paramycin, and liposomal amphotericin B are increasingly replacing antimonials in some areas, primarily where resistance has developed. Its epidemiology. L. tropica is found in urban environments. It causes anthroponotic cutaneous leishmaniasis or ACL through the vectors Phlebotomus sergenti and Phlebotomus papaticide. The lesions are dry and stay for an extended period of time without ulceration. After that, painless lesions such as papules, tubercles, or nodules disappear without scarring around 9 to 12 months.
Leishmania brasiliensis. The parasite biology of Leishmania is a vector-borne disease caused by obligatory intracellular protozoa of the genus Leishmania and spread by sandflies. Human infection is caused by about 21 to 30 species that infect mammals. The different species are morphologically and indistinguishable, but they can be differentiated by isoenzyme analysis, molecular methods, or monoclonal antibodies. Pathogenesis and clinical manifestation. Irregular fever, gradual pallor, spleen and liver enlargement, and subsequent rise in abdominal volume, lymphadenopathy, anorexia, and weight loss are all symptoms. So some changes in epidermal structures can be seen, such as dry, brittle, and depigmented hair, while the eyelashes are long and silky, pale skin and petechiae, ecchymosis and hemorrhagic suffusion, and occasionally jaundice as the condition develops. Edema is fairly common, especially in the lower limbs. So the data revealed a tendency to higher tissue parasitism is the skin compared to mucous lesion sites and a reduction with disease progression. Diagnosis. The lesions usually progress from papules to nodular flakes to ulcerative lesions with a raised border and center depression that can be covered by scrub or crust. So some nodules endure. The ulcerative lesions are normally asymptomatic, but they can be painful if they become infected with bacteria or if they are near a joint. So the treatment of Leishmanias brasiliensis is the efficacy of sodium, gluconate, and Lord, Lord, gingat ko di ang sa treatment na. So the treatment of Leishmanias brasiliensis is the efficacy of sodium stibogluconate and miltefosine in CL is well documented. However, clinical experience with liposomal amphotericin B and fluconazole or ketoconazole is in CL is limited. Epidemiology. Leishmania is a parasitic disease that affects 12 million individuals globally and mostly in rural areas. So each year, an estimated 1.5 to 2 million new cases of CL are reported, with 90% of these cases coming from 10 countries: Afghanistan, Iraq, Iran, Saudi Arabia, Algeria, Ethiopia, Sudan, Syria, Brazil, and Peru. Prevention and control. There is evidence that pesticide soak, mosquito nets, curtains, and clothing can be used for protection. No vaccine is currently available. So, but some districts, or such as Uzbekistan and Sri Lanka, encourage leash manipulation to directly inoculate viable parasites into areas that are not cosmetically visible.
Leishmanias donovani. Parasite biology, visceral leishmaniasis caused by leishmania, the most severe in the of these disorders. Leishmania parasites go through the several developmental stages during their life cycle, including the metacyclogenesis and the differentiation of metacyclic uh, promastigotes and the amistigotes. So, leishmaniasis is a vector-borne disease that is transmitted by sandflies and caused by obligate intracellular protozoa of the genus Leishmania. Pathogenesis and clinical manifestation. So, the target cells are those of a mononuclear phagocyte system. The two main tissue of infection are spleen and liver. So, clinical symptoms include pyrexia. This recur for high fever, with may be continuous or remittent. So, enlargement of spleen and liver and heavy skin pigmentation, which darkens the physical appearance, the reason for naming of black fever. So diagnosis, um, it can be diagnosed through microscopy, vitro and vivo isolation, vivo immune response, antibody detection, and molecular diagnosis. Treatment. Sodium antimony gluconate up to 25% resistance. So the resistance of sibogluconate should be treated with alternate agents such as liposomal amphotericin, pentamidine, and aminoside. And the combination of stabogluconate with drugs such as aminoside and interferon gamma. Epidemiology, it is estimated that visceral leishmaniasis affects more than 100 million people worldwide, with 1.5 to 2 million new cases and more than 750,000 deaths each year. As the 2022 report, there were 50,000 to 90,000 infections worldwide in 2020, and the World Health Organization estimates that only between 25 to 45% of the cases were reported. Although Eldovani is only the second most prevalent leishmania causing VL, it is the most dangerous form and directly fatal to humans. Prevention control, prevention and control, wearing that covers as much skin as possible, long pants, long sleeve shirts tucked into pants, and high socks are recommended. Also use insect repellent on any exposed skin and on ends of your pants and sleeves. So the most effective insect repellents contain DEET.
So, good day. I'm gonna talk about the microsporidia. So, here is the picture of the microsporidia parasite. So, first I'm gonna talk about the parasite biology. So, microsporidia are obligate intracellular spore-forming parasite fungi that cause opportunistic infections worldwide. So, spores are in an infective stage and can resist adverse environmental conditions. So, microsporidiosis is primary opportunistic infection of AIDS, with most infections being intestinal, although the dissemination to virtually any body tissue can occur. So next I'm going to talk about the microsporidial life cycle. So spores are ingested or inhaled from environment, then infected sporoplasm enters the host cell through the polar tubule. Microsporidia then multiply by merogamy and schizogamy in host cell cytoplasm or within the vacuole. Sporogamy occurs producing thick wood spore, and once enough spores have been produced in host cell cytoplasm or vacuole, cell membrane is disrupted and spores are released, and then spores can infect new cells or be passed in species. And then spores can infect new cells to be passed in feces, and the cycle continues. So while the transmission is not yet fully understood, infection is likely transmitted through inhalation or ingestion of spores from the environment or zoonotic sources. So human to human and animal to human transmission is possible. So next is the pathogenesis and clinical manifestations. So microsporidia cause opportunistic infections primarily but not always in severely immunocompromised patients with acquired immunodeficiency syndrome or the AIDS. So infection in immunocompromised hosts can lead to overwhelming disease and death. So clinical manifestations depend on microsporidian species causing the infection. So disease in almost any part of the body is possible. So next we have the diagnosis. So staining of clinical specimens with modified triachrome stain or chemiluminescent stain is standard for diagnosis in most laboratories. So suspicious level identification is possible by transmission of electron microscopy or the PCR. So next we have the treatment. So the intestinal infections caused by this are treated with famotidine, but this has been associated with adverse events. Initiation or optimization of antiretroviral therapy for immune restoration has been associated with complete resolution of intestinal symptoms associated with microsporidia infection. So next we have the epidemiology. So microsporidia are obligate intracellular spore-forming parasite fungi that cause the opportunistic infections worldwide. So the distribution of this parasite is also worldwide. Thus microsporidia are true eukaryotes closely related to the zygomycetes, which smallest eukaryotic genome known to exist. Microsporidia are treated as protozoan parasites in most laboratories, although their classification may change to fungi in the future. So next, the prevention and control. So because of lack of knowledge about infection transmission, methods for prevention are not fully understood yet. So personal hygiene measures likely play an important role in the prevention and control of microsporidia parasite. So these are our references.